Welcome to the Bronchiectasis and NTM 360 podcast, where we're here to share valuable insight from leading health experts, heartwarming stories from people living with bronchiectasis and NTM lung disease, and the latest in health research and treatment. Please subscribe, follow us on social media, and visit bronchiectasis and NTM360.org to learn more. Just a quick note before we get started. This podcast series is intended for educational purposes only and is not a substitute for medical advice. Please consult with your medical provider if you have any questions. Welcome back to the Bronchiectasis and NTM 360 podcast. Today we have a special guest, Dr. Timothy Asksamit. Welcome. Can you just tell us a little bit about yourself?
Thanks, Alyssa, and it really is a great pleasure to be with all of you today. I'm a pulmonary disease and critical care medicine physician and professor of medicine from Mayo Clinic in Rochester, Minnesota. I've been a provider, an educator, a clinical researcher in this space for more than 30 years. I've had the additional privilege to be part of the U.S. Bronchiectasis and NTM Research Registry since its inception in 2007 and chaired this for a number of years. Most recently, I've participated and been the medical director of the Bronchiectasis and NTM 360 platform.
Thank you so much for joining us today, Dr. Asksamit. It's always such a special treat to have you. Today, we're going to be talking about bronchiectasis and specifically, how does it form in the lungs? What happened? What's the process? So first, in order to understand that, we need to take it back to the basics and understand how do the lungs work. So air passes through the nose and the mouth, and then it enters into the main windpipe called the trachea. That air that we breathe in then enters into the lungs. And here the air passes through tiny tubes called the bronchi, and these bronchi secrete mucus or secretions naturally to trap any sort of dirt or any particles that enter into the lungs. These tubes have these tiny little hairs called cilia. Cilia is what helps those secretions to move up and out that mucus so that way you don't get lung infections and all that gunk can move out of your lungs. When an individual has bronchiectasis, this process is blunted. So simply, they don't work the way that they should. They lose their structure. And this is because those bronchioles that we just talked about, they become inflamed and they lose that structure. They lose their ability to move up and out those secretions as effectively. They start to pool them and trap them. So when you have inflamed bronchioles, inflammation is just the body's natural way to fight against any sort of infection or other invaders that have entered the lungs. The body sends this tiny little army of cells to fight whatever is in the lungs, and when they do that, if they remain for too long or if they repeatedly return, they cause damage. They cause scarring, those bronchioles become widened, they lose their structure, and again, mucus starts to be pooled. So, Dr. Asksamit, could you just explain this a little bit further for us?
This is a very important and a great question of exactly what is bronchiectasis. And in adults, we think about bronchiectasis, and I think about it as a dilation and a scarring of the bronchial tubes. And it's important to realize that that scarring is like a scar anywhere else. So, for example, I often use the example that if we were to cut our finger and that cut heals, there's a scar there. And as much as that's healed, that scar really never goes away. And in a similar fashion with bronchiectasis, as a result of either repeated infections or inflammation or other insults to the airways, there's a scarring that occurs. So our goal really isn't to ever make that scarring go away. Our goal is to prevent that scar or that dilation from getting worse. And all the other interventions and the approach to the therapeutic plan is really designed not to, again, make that scar go away, but to prevent it from getting worse.
Bronchiectasis is a chronic lung condition. So chronic means lifelong. This damage makes it really difficult for the lungs to clear mucus and again causes that buildup or trapping of that bacteria. Dr. Asksamit, could you just tell us about that vicious cycle that you alluded to before?
This is, again, another one of those really important aspects of bronchiectasis. And with this scarring or dilation of the bronchial tubes, the efficiency that we clear the normal mucus that we make in our airways is decreased. And so, as a result of this, the normal mucus has a tendency to pool or be retained in the airways. And with that retention, that's a great place for the germs that normally reside in our airways to grow, cause more infection with inflammation, more damage, and set up a cycle. And some have labeled this a vicious vortex or a vicious cycle. And our goal here really is to prevent that or to break that cycle. And we do that primarily with airway clearance. And again, that's designed to try to reduce that pooling or retention of the normal mucus in our airway so that we don't have these recurrent infections and that ongoing inflammation to further damage the airways.
So, bronchiectasis is not considered a rare disease, and many studies suggest it's actually underdiagnosed as it can accompany other diseases like COPD and asthma, and it can be mistaken for other diseases as well. How common would you say bronchiectasis is?
So bronchiectasis is not an uncommon condition. It's being increasingly recognized as more prevalent around the world and in the US in particular. We understand that this is really a problem that's associated with aging. That is to say, as we get into our sixth, seventh, and eighth decades of life, the incidence goes up dramatically. Exactly what those contributing factors are uncertain, but it is increase. And in fact, when we look at a large database of healthcare individuals over 65, the incidence is about 562 per 100,000. So that's about the same rate as breast cancer, and that's in individuals over 65. So, as a point of reference, as we get older, the incidence goes up, and the incidence is about as common as breast cancer.
When should they be concerned if they have bronchiectasis?
It's important that we try to recognize early signs and symptoms of bronchiectasis so that we can respond and interrupt that vicious cycle or vortex and to prevent worsening damage to the bronchial tubes. So, when should we be worried about this? Most of us think that if there is a chronic cough, especially with sputum production or frequent chest infections, that continue to come back despite a course of antibiotics, that we think about this. It's also very common to sometimes have a label of asthma or emphysema or COPD when in fact there's a component of bronchiectasis. We generally encourage patients to raise this concern or a question with their providers when they have this chronic cough that is productive of sputum, frequent antibiotic use, or frequent chest infections.
So, when I was practicing in respiratory, if I had a patient come into the hospital, if they came in 3 times in a year with a lung infection, that was always something that I did. I always encouraged the provider to send them out for a high resolution CT to see if that was something that they had, because they just kept on having to take antibiotics. And these were even just episodes where they were hospitalized, not to say that they went to their provider and got antibiotics in addition to that. So I just thought that was really interesting that, not a lot of providers in a hospital setting really look for that. I think because, too, it's not something that is super common. They really just look for COPD or asthma. They don't look to see, is it bronchiectasis, until it's kind of pointed out. Would you encourage them to get more like education in that sense? Do you feel that there's a gap there?
Absolutely. And this is another great point that when individuals, and not only when you're hospitalized, but even in the outpatient environment, if you find that you're taking 2 or 3 or more courses of antibiotics for chest infections over a year period, that's the time to at least raise the concern with your provider. And it would be very reasonable that in addition to the other tests that you may receive, is make sure that there is a high resolution high-resolution chest CT scan done to see if there is a component of bronchiectasis that's contributing to this. I might add that there are other reasons to have frequent chest infections and require frequent antibiotics, but it should be considered as possible, and chest CT scan is indicated when we find ourselves taking frequent antibiotics, and that's defined somewhere between 2 and 3 times per year.
Do you think that a patient could have a CT and then maybe a doctor not diagnose bronchiectasis, but really they have it on their CT? Is that imaging subjective?
Generally not. In most instances, the CT scan is a very sensitive and specific diagnostic test. In fact, oftentimes patients, if they have evaluation, say in the emergency department for chest symptoms, and there's a concern, say, for a pulmonary embolism, in most instances they'll get a chest CT scan. The scan comes back and said no evidence of a blood clot in the lungs. However, there are findings to suggest bronchiectasis. So our diagnostic gold standard these days is a chest CT scan, and we would expect, if there is bronchiectasis present, to pick that up on a scan.
So a lot of patients, when they go into the ER, they might get an X-ray. And is there something on the X-ray that would indicate them to get a CT?
With more advanced bronchiectasis, the chest X-ray will be abnormal, but by by all standards, a chest CT scan is far more sensitive and specific for bronchiectasis than a chest X-ray, and is considered the gold standard. So a CT scan is the way to go.
Thank you so much for joining us today, Dr. Asksamit. Just to summarize our conversation, there could be an indication that you have bronchiectasis if you have a daily productive cough with large amounts of mucus that lasts at least 8 weeks. However, according to NIH studies, they have stated that 27% of people with bronchiectasis have a dry, non-productive cough, meaning they don't have that mucus production with their cough. Other signs and symptoms that you should be aware of would be shortness of breath, feeling run down, feeling tired, chest pain, fever, and even increase in wheezing. There is good news in the bronchiectasis world. Bronchiectasis awareness has increased in recent decades, and Bronchiectasis and NTM 360 actually coordinates World Bronchiectasis Day that is observed every July 1st of every year to raise awareness and education globally, because there is a worldwide underestimation of the disease across healthcare professionals and different settings. It's not uncommon for the diagnosis to be delayed anywhere from 12 to 17 years, which ultimately leads to the progression and worsening outcomes for those who are affected. So continue to be your own advocate, continue to ask questions, and as Dr. Asksamit mentioned, reoccurring infections are not normal and could be an indication of bronchiectasis or another lung condition. So requesting a high-resolution chest CT is perfectly reasonable to help you find your answers. Thank you for tuning in to the Bronchiectasis and NTM 360 podcast. We hope that you found today's episode helpful and inspiring. You can stay connected by joining our online community, following our social media, and visiting our website for more resources. And of course, subscribe to this podcast and join us next time for more insight, stories, and tips to help you live well with bronchiectasis and NTM lung disease. Until then, thanks for listening and be well.